and I'm a former graduate of TSU. I graduated class of 2011.
Yay!
All right, so I'm really excited to be here today. My last few lectures have been in a virtual space, so it's cool to be able to put faces to the audience and be able to interact and engage with you guys. And hopefully I hope that you take some clinical pearls with you guys as you go to your IPPs and APPs, because I feel like this is a topic that a lot of learners struggle with. Insulin can be complicated, injections can be complicated, and it can be complicated for learners and for patients. So the better we understand it, the better we can help our patients meet their health goals. So learning objectives for today are to review the pathophysiology of both type 1 and type 2 diabetes. We're going to talk about the current guidelines briefly and look at the recommended treatment goals. We're going to discuss the available injectable treatment options for diabetes management, including some special formulations that you may or may not see in clinical practice. We're going to briefly highlight landmark clinical trials that are related to the injectable diabetes agents, and we're going to identify pertinent patient counseling points for the proper use of injectable agents. So this section requires a lot of memorization. So you're going to spend your time just memorizing things, matching branded generic, matching insulins and their duration of action. And to kind of help you guys focus, I put small gold stars on slides that I think they'll be helpful for you when you're reviewing for my portion of the exam. And in order to make the lecture a little interactive, I have added knowledge questions throughout that we can discuss as a group to keep you guys engaged and help assess your knowledge, how to see where you are. So let's jump into the pathophys. We have our pancreas, which is a little small organ that's very powerful, and it's part of our GI system. It sits behind the stomach and the liver, and its job is to produce insulin whenever there's a sugar spike or whenever there's a lot of sugar in the bloodstream. People living with type 1 diabetes don't have that function working. Maybe it's because the beta cells of the pancreas have been destroyed through an autoimmune process. And so for these patients, insulin therapy is essential. They have to have it. It's mandatory. And type 1 diabetes makes up about 5 to 10% of all diabetes cases. However, but when you switch to type 2 diabetes, over time, the beta cells of the pancreas stop working. And type 2 diabetes is more associated with insulin resistance, meaning your body's making a little bit, but the body doesn't know how to use it properly, which is why we add insulin therapy to those patients. And this represents about 90 to 95% of diabetes cases. So this chart I thought was pretty interesting because it helps to show that by the time a patient is diagnosed with type 2 diabetes, the beta cells of the pancreas have already declined and function by 50%. And it's a progressive disease, and over time, the beta cell function will likely decline, meaning that patients will likely require combination agents to manage their diabetes, or they'll likely require injectable therapy. So this is something that patients need to understand at the time of diagnosis. This is something that they'll have to manage throughout their lifetime, and that's doable, and they can do it because of the progressive nature of this disease. So this is a picture that you guys might see in textbooks, but it references what's called the Omnius octet, and basically it's representing the multi-pathophysiological disease process that's happening in type 2 diabetes and how we're able to, and how it leads to hyperglycemia or elevated blood sugars. So the pancreas we talked about, it's not making enough insulin. Or we have the kidneys that are reabsorbing sugar instead of excreting it. Or maybe the incretins in the tummy, they're not producing the hormone to help lower blood sugars. Or your liver is constantly producing sugar. And all of these multi-pathophysiologic processes lead to hyperglycemia or elevated blood sugar in your body. And if you start paying attention to your mechanism of actions of your drugs, whether it's oral or injectable, they're targeting these areas. So your SGLT2 inhibitors are targeting glucose reabsorption. The incretins are being targeted by GLP-1s, or insulin is helping the pancreas do its job. So that's where we target our drug therapy. So it's important just to kind of put everything together as a big picture. So most practitioners refer to two main sources for assistance with diabetes management. We have the American Association of Clinical Endocrinologists guidelines, or the AACE guidelines, or ACE guidelines, and it was last updated in 2020. And my institution, we use the ADA. We use the American Diabetes Association Standards of Medical Care in Diabetes. It's a big guideline that's published every year. It drops in January. So if you're ever assigned to my rotation, you'll be required to look at the abridged version, which is about 29 pages. And I always have my learners take a look at it to make sure they're up to speed on diabetes management, because that's probably what I spend about 70% of my day doing, is diabetes management. And I like the abridged version because it provides an overview and it's not as in-depth as the large one that endocrinologists might use. So the treatment goals are different depending on which guideline we use. I'm pretty sure you guys have seen this before. The Endocrinology Association recommends a more stringent A1C goal of less than 6.5%, but the ADA recommends an A1C goal of less than 7, with your fasting sugars being between 80 and 130, and your postprandial sugars being less than 180. And I always tell my patients, if you're seeing sugars of 200, that's too high, just to give them a frame of reference of what they're looking at when they're doing glucose testing. And of course, your treatment goals should be individualized based on the patient. You have to meet the patient where they are. So patients that are prone to having hypoglycemia, like if they're elderly or frail, or if they have brittle diabetes, you might have a different goal for them. If they're on hospice, they have a short life expectancy, maybe they're battling cancer, or have other comorbidities, the glycemic targets might be different. And we always want to consider patient preferences and other socioeconomic factors such as cost and what the patients can afford. Thank you. All right. So in my practice, I see adults aged 18 and up. I do have some geriatric patients in my practice, but in the case that you are on rotations, doing your APPEs, and you might have a special population that you work with, there are resources available to you. So if you're working with children and adolescents, the big ADA guidelines have a chapter specifically dedicated to pediatric diabetes and how to manage diabetes in that population. And if you are working with elderly, there's a supplement in the ADA for that population, as well as supplemental information located in the Beers criteria. The Beers list was last updated in 2019, and it should have an update soon in 2022 or 2023. So when you guys are ready to take your name pledge, you might want to review that. Or by the time you guys get to your APPE rotations, it should be updated. And then lastly, there's support for managing patients when pregnant. So in my practice, I do see women of childbearing age. If I suspect they might be pregnant, we order pregnancy tests. If it's confirmed it's pregnant, then we transition them to have diabetes management with the OB or GYN. So it's not something I do in my practice, because their goals are a lot more stringent and their follow-up is more frequent when managing gestational diabetes. All right, so this is a chart you guys have probably seen a lot. That's referenced from the ADA, and I just wanted to show how much the guidelines recommend injectable therapy. So you can use injectable therapy for people who might have an ASCVD indicator, if they're living with chronic kidney disease, if they might be at risk for hypoglycemia, or if they might want to promote weight loss, then GLP-1s might be a good option. And let's say cost is an issue and some medicine might be too expensive, then we still have our more affordable insulin options like NPH. So the guidelines highly recommend injectable agents, which is why patients shouldn't be threatened to inject. They shouldn't be scared to inject, because this is what's used and this is what's recommended to help control their condition, and it's recommended early on. So right after metformin and lifestyle modifications, they can start injecting medications. So this part of the chart of the guidelines shows that in some patients, a GLP-1 injection might be preferred over insulin. So that might be the preferred injection, depending on certain clinical situations. And in the event that the patient is on a GLP-1 and they're not meeting their goals, you can add insulin therapy. And in the algorithm to the side, it can also work the other way. So let's say the patient's already on insulin, never got a chance to try GLP-1, they're not meeting their target. you can add a GLP-1 to insulin therapy. So as you guys are studying for your courses, just read the fine print. I also recommend reading the subheadings sometimes because they have extra information that's not listed in the charts when you're reviewing for your exam. So let's jump into our
You mentioned after metformin, they can go straight to injections?
They can.
Oh, okay.
Yes, they can. So depending on whatever indicator they might have, whether if they're living with cardiovascular disease, you can use a GLP-1 that has cardiovascular benefit. Or if they have chronic kidney disease, you can use one that's safe in renal dysfunction. So if the patient's willing to inject, give it to them. Don't threaten them or scare them with injections. All right, so we have 3 classes, that's it. 3 classes we're gonna talk about, but we're gonna talk about them in depth. We have the amylin analog class, our GLP-1s, and then our insulin therapy, our basal, bolus, and mixed therapy. Okay. And for completion, I have listed the current top 300 drugs applicable to this class, right? So it's commonly seen in practice, no matter what setting. It could be inpatient, outpatient, ambulatory care, you're gonna come across these drugs. So my expectation is that you know the brain is generic and how to classify these agents as if they're long-acting, rapid-acting, short-acting, because you're gonna see them. And as you know, there's multiple trade names that could be interchangeable. So make sure you know all of the available names. And I listed them here for you. And the chart should be complete, but just compare it to your textbook, your current textbook, just in case something's missed. All right, so we're gonna jump into our first class, the amylin analog. So amylin itself is a hormone that is secreted with insulin from the beta cells of the pancreas. So an analog means that it's a man-made version of what the body does naturally, right? So this is a synthetic analog of human amylin, and it helps patients feel full faster, it slows down gastric emptying in the stomach, and it does glucose-dependent inhibition of glucagon secretion. So basically, whenever it feels sugars rising, it starts inhibiting glucagon secretion in the body. The A1C lowering is modest, it's about 0.5 to 0.7%, and this product works on mealtime sugars, so postprandial glucose values. Potential side effects are nausea, vomiting, weight loss, and hypoglycemia, which can be very severe.
Excuse me, ma'am, just to clarify, you said they're gonna be little stars as we go along?
Mm-hmm.
Okay.
Yes, so you have to look for them. All right, so thank you for bringing that to everybody's attention. So continuing on, because of how this drug works and because it kind of slows down things moving through the tummy, there are some clinically significant drug interactions. So any medicines that need to be absorbed right away, such as pain medicines, antibiotics, birth control, you want to separate the injection from those products. And it's recommended 1 hour before or 2 hours after the injection. So basically not at the same time of anything that might be acute medication. When you put a patient on an amylin analog, you want to monitor their A1C and their blood sugar levels, like how they're doing, how the patients are doing at home. Some notable clinical pearls are that this drug has to be dispensed with a medication guide. So if you're working in a retail setting and you get your drug labels, there's going to be a medication guide that comes with it, with the packet of information for the patient. One thing to note about the amylin analog is that it's used as an adjunct to insulin therapy. So that means a patient has to already be using insulin, basal bolus insulin, before you can add this product. Any patient who doesn't want to check their sugars should not use this medicine because the risk of hypoglycemia is so severe and it can be deadly. And whenever you add the amylin analog, you should decrease the insulin dose by 50%. Okay, so it's something that you want to make sure you put in your mind. And because how it works in the tummy, anybody living with gastroparesis or diabetic gastroparesis should not use this product. So the only available drug in this class is called pramlintide or simlipin. I tried to put pictures of each of the products for you to kind of give you a visual. And I also bought some demos of some of the things that I have, so you guys can kind of play with them and get used to the injectable products. And we'll do some practice counseling with those products today. So the cool thing about the Symlin product is that it can be used to manage both type 1 and type 2 diabetes. So it's used for both, because a lot of people think that people living with type 1 diabetes can only use insulin, but it's not true. We do have another option available to them.
I'm gonna see here where I'm on.
Okay, all right, so the dosing schedule is different. So if a patient's living with type 1 diabetes, the recommended dosing is 15 micrograms under the skin with meals 3 times a day. So this is something that we'll inject 3 times a day into their bodies. And you can titrate the dose by increments of 15 micrograms up to a max dose of 60 micrograms with meals 3 times a day. And the dose for type 2 diabetes is a little higher. You start them on a dose of 60 micrograms under the skin with meals daily, and you can titrate up to 120 micrograms for those patients. And the 60 microgram pen, when you turn the dial, you can turn it to 15, 30, 45, and 60, so the patients can work their way up to the target dose. And for the Symlin pen, you can only turn it to 2 doses, the 60 and the 120. So patient counseling is really important. Because of the risk of hypoglycemia, patients have to take this medicine with food. And the food has to be an actual meal. So it's recommended to eat at least 250 calories or 30 grams of carbs. And I listed some examples of 30 grams of carbs for you. If the patient misses a dose, they go on to the next meal. Never double up or try to take extra because it could be dangerous. And it's recommended to inject this product in the abdomen or thigh. And it's good for 30 days at room temperature once you start opening the pen and using the pen. And it's recommended that patients that are using this amylin analog are prescribed like a glucagon injection, or they take glucose tablets or gels because the hypoglycemia can be so severe. So you guys see our gold star? Yeah. Okay, cool. All right, so the guidelines now have done a good job of including cost to let clinicians know how much these agents are, because some of this stuff is pricey. So just for reference, the max dose of the amylin mimetic is about $3,000. It's cut off here, but I think it was like $2,700 for a pen, which is very expensive. But there are patient assistance programs and co-pay cards available for this product. So we'll do a quick knowledge check. Feel free to participate. Oh, we got a question. I'm sorry.
Oh, you didn't see what's on?
Huh?
You like you just not seeing me?
Yeah, I'm so sorry. I'm in my own head.
So for the analog,
Yes.
I know you said it's used as an adjunct. Can it be used for monotherapy? And as far as the adjunct, can you use this when your glucose levels are not being managed by the current therapy or separate?
So yes, it's adjunct, meaning the patient has to be on basal bolus insulin. So it would not be monotherapy. Okay?
Never.
It would not be monotherapy. No, it shouldn't be. No. And then you asked the second part. Yes, it's when they're not meeting the goals. So my ideal patient, let me give you a breakdown of who my ideal patient for this drug would be. So they're on basal bolus insulin, which means they're probably injecting what? Minimum 4 times a day. Then I'm about to give them medicine to inject separately.
3 times.
That's 7 posts at minimum. That's 7. So my ideal patient would be living with type 1 diabetes, and they're on a pump, and they're on an insulin pump, and they're not meeting their goals. Yes. So instead of increasing their insulin, we're going to just give them an adjunct therapy to get their sugars to goal. So in my practice, let me back up. I've only managed pump patients 2 times. And the time that I've been working in ambulatory care, pumps are usually managed by endocrinologists. So it's usually more advanced because there's a lot of steps that go into a pump, but there are pharmacists who are very knowledgeable with pumps. And so that's the only person that I would kind of see myself giving this medicine to, if they're living with type 1 or type 2 diabetes and they're on an insulin pump. Because if not, who's gonna poke that many times a day?
So quick question.
Sure.
If someone is on a pump, and let's say they just don't manage their diabetes, or they're just like a 21-year-old who just wants to go out and drink, they're on a pump, they think that works, but it's not, clearly they need to go to the hospital every 3 weeks.
Yes.
They drink Pedialyte, et cetera, et cetera. would you give this to that person?
No.
No?
No, you have to be focused. Did you see the meal requirements? They gotta eat,
Yeah.
they have to be
It's
consistent.
too much, man.
Yes, and then they have to be willing to check. If you're 21 out here living your best life, you're not trying to check your sugar.
No, I was just saying.
But I'm just saying,
This is
for
the
the-
adjunct, okay, maybe we should implement this to kind
Well,
of keep you from
you
all the
could-
hospital.
You could when the patient is ready. The patient has to be
They
ready.
have to be like mature enough to do
Yes,
it.
so, because in the hypoglycemia, like when you start reading about this product, it's really bad. That's a reason to be put in the hospital. And this drug is not really used. If you look at the algorithm for the ADA, it's not there because they have other options. So, but I just, as pharmacists, this is something we should know about because there's some clinical pearls associated with this medication, and it is an option. So let's say you do have a person who's motivated and they're on a pump and they got their A1C from 15 to 8. We might need a little similar if they're ready, right? So that's a great question, just to put it in perspective. And I saw a second hand. Yes.
I have two things. One, I know when we were talking about the ambulant analog, you said like you would see the gold stars.
Yeah.
I don't have any gold stars.
So on your student view, you will not have gold stars. So in order, I want you guys to be paying attention. So,
Oh, okay.
so the people that
So
are
we just
here,
wonder already, is what.
well,
If
so.
you look at the page, you ain't look at the page, you ain't got a single song.
Okay, so,
And then I have something.
yes.
The microphone is like right here, and so it's kind of like scratching a little bit.
I don't even know where I
on
put
the
it.
other side.
Okay.
Oh, yeah.
Or just like, yeah, it keeps
I'm so sorry. Thank you.
It's okay.
Alright. Okay, now, let's do a knowledge check as a group, alright? So who wants to read it? Somebody wanna read it? For the group? Okay, anybody, take it? I appreciate volunteers.
We have a reader, but I'll read today.
Okay, go ahead.
Pramlintide is dosed 120 mcgs under the skin 3 times a day with meals for persons living with type 1 diabetes.
Is that true or
Oh,
false?
60.
No, it's 3 times a
Yes,
day.
okay, but I wanted to give you guys an idea of what kind of questions I'll be asking you on exam, so it's gonna be very straight to the point, either you know or you don't. Okay, so the dosing, the max dosing for people living with type 1 diabetes is 60 micrograms. So if you're ever in a retail setting and you know the patient's living with type 1 and you see a dose of 120, you know that's incorrect for them, might want to call the doctor, okay? So that was pretty good, all right, awesome. Let's transition to our next drug class. This is my favorite, GLP-1.
I like them too.
So, they work by reducing gastric emptying, increasing fullness. The MOA is kind of similar to the insulin analog. However, they do something additional. They have glucose-dependent increase in insulin secretion, so they help the pancreas pump out a little bit more insulin when it's needed. And the A1C lowering depends on which product you're using. So GLP-1s are classified as either short-acting or long-acting. And so the A1C reduction is anywhere between 0.5 to 1.8%. Honestly, in clinical practice, I think it's higher, probably because the patients are just adherent. But I get some pretty good effects with GLP-1s. Short-acting GLP-1s primarily focus on mealtime sugars, and long-acting products focus on lowering both the fasting sugars and the postprandial sugars or mealtime sugars. So that's a slight difference. Potential side effects include nausea, vomiting, and diarrhea, which is very real, especially when patients first start the medicine or if their dose is increased. Headache, which goes away once they're used to medication. Injection site nodule, and we'll talk about that later, and it's specific to the exenatide extended release product. There's a risk for pancreatitis and renal dysfunction in some of the products. So you always have to kind of look and make sure that the patient is not diagnosed with chronic pancreatitis or they haven't been admitted in the hospital with pancreatitis recently, like a recent bout of pancreatitis before starting these agents. So some contraindications include gastroparesis because of how it works, and a family history of medullary thyroid carcinoma or thyroid C-cell tumors. As a pharmacist, I do not diagnose this, right? So before using this medication or doing my patient workups, I just go through the chart to make sure I don't see any previous diagnosis of these things. And also just ask the patient, like, do you have a family history of thyroid cancer? Or you kind of look, you know, their thyroid sits in the neck, so you look for scars. You look to see if they've ever had a surgery. Did you have your thyroid removed because you have cancer? And those are questions that you can just talk to patients about and ask them about. And in order to screen for these conditions, once the patient starts the medicine, I'll ask the patient if they're having hoarseness, trouble speaking, did they have a lump in their throat, anything like that, to let you know that maybe we need to stop this therapy. Some clinically significant drug interactions are similar to the amylin analogs because they slow gastric motility. We want to monitor the A1C and blood sugar levels in these patients and renal function. So there's some renal cutoffs with some of the products. So if the patient's using exenatide, we don't use it if the eGFR is less than 30. And if the patient's using lexatinide, then we don't use it if the eGFR is less than 15. So here I listed all of the available medications for you by generic and brand, and I also categorized them for you. So the categorization of short acting and long acting depends on their half-life. So the the lexatinide and the exenatide immediate release or Byetta are classified as short acting, and that's because their half-life is about 2 to 5 hours. But the other ones have a much longer half-life of up to, I'm gonna say 12 hours to several days, which is where you get into some of those once-weekly options. And to note, some of the GLP-1s are available in higher doses in order to help manage weight loss. So the Saxenda is high-dose liraglutide that's used for weight management but not diabetes. And same with Wegovy, which was recently approved, which is high-dose semaglutide. And to note, semaglutide has an oral formulation available called Rybelsus. So please be very familiar with your brain generic. So some clinical pearls. We have the potential for weight loss, with semaglutide being our most effective for weight loss. Some of our GLP-1s have proven cardiovascular benefit, and I've listed those there for you. Again, these are dispensed with a medication guide in the retail setting. Patient counseling, I really want to spend some time on that. These drugs work if the patient uses them. So I encourage patients that because of the nausea, the vomiting, and upset stomach that happens when you start the medicine, they have to increase their water. And if they're really nauseous, I tell them to drink like Diet 7-Up or Sprite Zero to help minimize that until their body gets used to the medication. And I tell them to eat smaller, more frequent, low-fat meals. If they're eating pizza, if they're eating greasy foods, if they're eating hamburgers, French fries, they will feel sick. They will feel stomach sick. And so it kind of helps the patients make better food choices, which how it helps patients lose weight. All right, so let's jump into our first agent. And I actually have a demo pen for Byetta. So Byetta was, I believe, the first GLP-1 that was released. So it's like the OG, right? So I'll let you guys pass it around, take a look at it, twist it, turn it. Some of these have needles, please don't poke yourself.
It's just a bunch of.
Yeah. So on the demo pens, there's no needle, so you can play with those freely. But I do have some syringe examples to have you guys see what the patient sees. So please don't hurt yourself. But play the dial. Sorry guys. Play the dial, pass around. So the exenatide immediate release. Remember, this would be our short-acting product. It has to be poked, it has to be put in the body 2 times per day, and it has a starting dose of 5 micrograms with a maintenance dose of 5 micrograms to 10 micrograms twice a day. So you can leave them on the 5 if they're meeting goals. If they're not meeting goals, you can titrate up to 10 twice a day. But you have to wait 4 weeks to do so. This is meal specific. So you give this medication 60 minutes before morning and evening meals. I've listed the injection sites there for you, and the pen is good for 30 days. So it has, so the Byetta is, the 5 mics is orange in color, and the 10 mics is 10 in color. It's not really used anymore. Some people still might be on it, but we have options where patients don't have to inject as much, but it's still currently available. And transition now, we have the extended release of exenatide, and it's called Bydureon. And they reformulated Bydureon 3 times. And they tried to make it more simple, because at first patients just had to mix it themselves before they injected it once weekly, and that was hard for them to do. So the Bydureon pen was recently discontinued during the pandemic in 2020. So now if you see Bydureon, it's only the B-size that's available. And patients only have to administer it once weekly, and there's only one dose, 2 milligrams. There's no titration or anything. Just give them 2 milligrams once weekly, and that's it. I listed the injection sites there for you. One pen is good for 4 weeks at room temperature. And when patients get the Bydureon, they'll get it in a box. It'll be 4 pens in a box if they get a 1 month supply. Now the Bydureon, at the time when it was created with what they call like a microsphere technology. And so it was to help the medication really slowly over time. So it takes about 10 weeks to reach steady state. And because of this technology, when a patient injects the Bydureon, they'll get a little bump in their skin, and it won't go away right away because the medicine's releasing. So it can be scary to a patient when you inject, you're like, why is this bump here? So I have to talk to them about that and let them know, hey, that's an indicator where you injected your last spot. Let's rotate and use a different spot next time. And it does go away after several weeks, but it can freak a patient out. But it's just because of how the drug was designed.
That's the reason why you should not take 2 doses within 3 days.
So that's to minimize side effects. It's designed once weekly. So for example, when I start patients on once weekly GLP-1s, I'll ask them what their injection date is. They might tell me Thursday. So we want to try to keep them on Thursdays if possible, and not try to do the doses too close together, because then they're more at risk for side effects. Right. And you'll see that a lot with the once weekly options. All right, the next available GLP-1 product is lixisenatide or Ablucin. I've never written for it in clinical practice, but it is available. It's dosed once daily, and it comes with a 10 microgram pen or a 20 microgram pen. You start the patient on 10 micrograms once a day for 14 days, and on day 15, they go up to 20 micrograms daily. And that is the maintenance dose and the max dose for this product. This one is meal specific, so patients will inject themselves 60 minutes before the first meal each day, and they have to be consistent. That's what's recommended. And a pen is only good for 14 days once they use it. So once they start using the product, it's only for 14 days, which is a counseling point for them. And it's created by the manufacturer the starting pack for when they get started, and then a maintenance pack for when they're on the maintenance dose. All right, so we have Trulicity or Dulaglutide, which is my favorite. It's one of my favorite GLP-1s. They have 4 available pens, and it's available as 0.75, 1.5, 3, and 4.5 milligrams, and they inject it once weekly. What's really cool about Trulicity, it's a good GLP-1 to use if patients are scared of needles. You don't see the needle. So to put it, let me see. So the patient will get a carton of 4, and it has like a little lock on here. So red means not ready, green means ready. And they'll pull off this base and literally just poke. That's it. They won't see the needle, nothing. And when it clicks back up with the second click, it's done. Once a week, that's it. So it's very simple. And so it's a good place to start for patients who might benefit from a GLP-1, who might be living with chronic kidney disease, or they might have an ASCD risk factor, or they want to lose weight, so that would be the place to start. So I really like Trulicity, and patients do pretty good with it. Now, you start low, and you can titrate up to the dose that you need, but you can only titrate every 4 weeks. So you can't go up too quickly. That can lead to side effects. And one pen is good for 14 days, but it's a one and done. They don't have to do anything. So once you inject, it goes in the trash. So you really don't have to really worry about expiration too much unless the patient's missing doses. And we talked about the available dosage forms. Okay. Next product is the Victoza pen. I really like Victoza as well. I think I have a pen. I have a Victoza pen too. So, Victoza is known as liraglutide, and the dosing is different. Physicians really struggle with this dosing of the Victoza. A lot of times they don't do it right. So you can turn the dial to 0.6 milligrams, and the patient will inject this once daily for a week. And this 0.6 milligrams does nothing for their sugars. It's just getting their body used to the medicine. And on day 8, they're gonna go up to 1.2 milligrams and stay there. And they stay there for 4 weeks. A lot of times in practice, the patients will be on 0.6 and they just stay on 0.6. They never went up, they never changed their dose, their sugars are still high. So that's an intervention that pharmacists can make. Now, let's say patients aren't meeting their goals after they've been on 1.2 milligram therapy for a while, then they can go up to a max dose of 1.8. So when you get the Victoza pen, it dials up to those 3 different doses. Now, what's really cool about Victoza is that it's the only GLP-1 that is FDA approved to manage type 2 diabetes in kids over the age of 10. Now, if patients are missing doses of Victoza, they miss more than 2 days, they have to start their titration over. They have to go back to the 0.6 and work their way back up to try to make the patient be as adherent as possible so they don't have to go back to retitration. All right, so our last one is the Ozempic or the semaglutide. Same thing, they have a starting dose that's not effective for glucose control of 0.25 milligrams once weekly for 4 weeks. After that initial 4 weeks, they go up to their maintenance dose, and then you can titrate up again to the max dose of 1 milligram weekly. If they miss more than 5 days from their last dose, they would skip the dose and go into their next scheduled dose, but try to keep it once weekly, consistent on the same day. This is the most stable, longest lasting GLP-1 at room temperature. It's good for 56 days, which I thought was good for patients. And they have 2 different pens depending on which dosing schedule that you're going to use. Now, semaglutide, as I mentioned before, is our most potent GLP-1, and it has cardiovascular benefits, and it's also the most effective. They compared it to like Lantus insulin, they compared it to Victoza, Bydureon, and semaglutide lowered A1Cs better. So if you're looking for maximum A1C lowering potential, then you might consider Ozempic in your patients. So remember, semaglutide has an injectable and an oral tablet, and you can convert back and forth. I'm not going to ask you guys about that, but just know that there is some conversions if necessary. So a patient might be on Ozempic, they're tired of injecting, you can transition them to the Rybelsus tablet if necessary. And again, the guidelines list the doses for GLP-1s. They run about $1,000, so they are pricey, but you can get them with copay cards and patient assistance programs. So there's some clinical trials associated with this drug class. They did cardiovascular outcome trials in, I think, 6 of the GLP-1s, and 3 of them showed superiority. So this is why they're listed here, and this is why they're recommended for patients living with cardiovascular disease, or if they're high risk for cardiovascular disease. So the leader trial was with liraglutide, the SUSTAIN-6 trial looked at semaglutide, and the REWIND trial looked at dulaglutide. And they were able to reduce stroke, cardiovascular risk, prevent worsening neuropathy, and help patients lose weight. So we'll go into some balance checks. Can I get my reader again? Or anything?
What is the trade name for dulaglutide?
Yes. Dulaglutide. Any takers?
Trulicity.
Oh. Alright, so Bydureon was the exenatide, Victoza was the liraglutide, Rybelsus is semaglutide.
Is this one of the stars?
It could be. Alright, next knowledge check question. Can I get a reader?
Which GLP-1 RA is available as an injection and a tablet?
But I don't need a reader for you guys.
No.
No, we're just.
Keep the. Oh, we're just.
Because we have
Such a
30
great-
other questions that are too hard.
Alright, can I get a reader?
Which GLP-1 RA is associated with the most weight reduction? I think semi.
Nice thing.
Is it?
We got
Because
some
the
A's.
high dose glutide is suggested. That's something like that.
Who said that? But what's the other name for Saxenda?
So, yes, okay, so the answer is actually C.
Yeah.
So remember the scale, so semaglutide provides more weight loss than
Mhm.
ribupatide. Okay, so that's the order.
There was a scale?
Huh?
There was a scale like that?
I had it in my thoughts. All right, we're gonna transition to insulin, guys.
Can you go back?
Yeah. It is. It's on our GLP-1 card.
Just do the first three letters, y'all.
Y'all ready?
First three letters.
Mm-hmm.
All right, so
But I know
insulin.
semi for a fact. That he was the-
So insulin works like the insulin that our bodies already produce. And it helps to stimulate peripheral glucose uptake in the body and it inhibits glucose production in the liver. So the cool thing about insulin is that it can lower any A1C. So my highest A1C to date in my career was 20.3%. That's my highest. And we put this patient on insulin therapy. And within their first A1C, we got him down to 8. And then I added him a 1-2 GLP-1 and we were able to get him down to about 7.2. So that's where he's at. But there is no limitations with insulin, which is why patients should be scared of insulin, because it can get them to goal if they're using it and if it's dosed properly.
With the patient, with the A1C that high, are y'all still looking at a 6.5 A1C goal or dropping 10?
Seven. Well, for our institution, we use 88. So
Oh, but that's 7.
that's just, it just depends on your practice, but we try to get them to the goal of up to 7.
Was that patient conscious?
He was in the hospital. I got him out of the hospital, and he was also incarcerated. So our first visit, he came in with a monitor on. So he just wasn't taking care of himself, but he learned to. And insulin can be life-saving, so there is no A1C lowering. There's unlimited A1C lowering. So some of the side effects associated with insulin is weight gain. Patients can gain anywhere between 2 and 4 kilos of weight. And there is a risk of hypoglycemia. And it's higher with patients who might be on dialysis. You might have to go low and slow with their insulin titration, or if they have liver dysfunction. And because patients have to inject this multiple times a day, it's possible to have injection site reactions. And of course, we want to monitor patients' A1C and glucose levels when using insulin therapy. So, contraindications are allergies to any insulin product. In clinical practice, I've noticed that patients who have latex allergies don't really do well with like Humalog quick pen products because those quick pens are made with latex. So that's like the only hypersensitivity one that I've seen, but it is possible that people could be allergic to injection.
The slide before.
The slide before?
Yes, that has to do with insulin. You don't want to do all this, the way you do it.
One more?
Oh, the one that you asked in the morning.
Yeah, the more you know,
It's a little off, I tried to place it. One of my students showed me this mnemonic and they wrote insulin and it helped them to remember which one was what class.
that's what I'm saying. So, arachidonic, how do you, can
I
you
can show you.
You were long with me, right?
We can show you.
Well, I'll show you.
Okay.
Just a little off.
Yeah, I tried to place it as best as possible.
It's okay.
Okay, so, clinically significant drug interactions include beta blockers. So, beta blockers can mask symptoms of hypoglycemia. So if a patient's being started on a beta blocker or their dose is being titrated, you might want to counsel the patient to start testing more often. Patients that are on 4 kilograms for acute therapy might notice that their sugars go up or down. They might have to check their sugars more when using insulin therapy. Metoclopramide is used to treat diabetic gastroparesis, and those patients might notice that they're more at risk for having elevated sugars when on metoclopramide therapy. And these herbals, ginkgo, fenugreek, and ginseng, have been linked to cause hypoglycemia. So it's important to counsel patients about herbal products when they're using insulin. All right, so here's our available medicines. It's a lot, right? You're gonna probably have to go back to flashcards. How are you guys best memorize things to make sure you keep it straight? We have the categories here: very rapid acting insulin, which includes Fios and Lumjug. Lumjug is kind of new. It's a recombinant insulin. They put a little bit of technology with it to make the onset quicker. And so it helps give flexibility to patients when they're injecting insulin for their meals. Then we have a rapid acting insulin, which includes Lispro, Aspart, Flulysine, and inhaled insulin. And I have the trade names here for you. We have our short acting insulin, which is our human regular, also known as Novolin R and Humulin R. We have our intermediate insulins, NPH, and concentrated insulin, our most concentrated insulin, V500. We have our long acting products, which is Levemir and Lantus, as well as some of these biosimilars here. And then we have our ultra long acting, and these insulins are concentrated, and that's the Tresiba and the TJO. So the rule of thumb, if you don't see a number behind the insulin product name, it's considered U100. But when you start seeing U200, U300, U500, you know those are more concentrated insulins. And just to try to explain that to you guys a little bit better, because when I was first learning insulin, I was like, what is this? So if you don't see a number, it's understood that it's U100 unless there's a concentration in mind. We also have some mixed preparations, some mixed insulin products, and they might be mixed with NPH, or they might have like a rapid acting insulin or insulin analog mixed together to give patients some flexibility and reduce the amount of pokes they have to use. And I have the trade names listed for you. So you see that there's 70, 30, 75, 25, 50, 50. So the 70 is designates the amount or the percentage of the long-acting product. So the long-acting product is first. So 70% long, 30% rapid. 75% long, 25% rapid, and so on. And then they also have some insulins and GLP-1s mixed together that's come out here recently, which I think is pretty awesome for some patients. And they're known as Zoltify and Soliqua, and we'll go through those a little later in the presentation. Alright, so here is a comparison of insulin products. You're gonna have to take some time to meditate on that. It's a lot to kind of look at here. But it's important to understand your onset, which is how quickly the drug is gonna work once the patient injects it. The peak is when the insulin is at its strongest, when it's at its highest action. And the peak time is also when the patient is more at risk for hypoglycemia. So that's when you want their patient to kind of check their sugar or pay attention to how they feel during the times that you might suspect that insulin might be peaking. And the duration of action is how long, of course, it stays in the body. And you see the onset gets, how it listed from shortest onset to longest onset. And notice that when you get to your long-acting insulins, there is no peak, so there is a less risk of hypoglycemia when using that insulin product by itself. You start having hypoglycemia when you start adding mealtime insulin, okay? Now, those U300s, U200s at the bottom, those ultra long-acting products, they're peakless and they last greater than 24 hours in the body. So they provide good long coverage for patient sugars. And then we have the mixed insulins here. It's cut off on here, but I think the onset is 30. It peaks in, I think, around 2 hours. It starts to peak, and it lasts between 18 and 24 hours.
When you say it doesn't peak, are you saying it doesn't have like a maximum amount of that's consistent, that kind of thing, or you saying like, what do you mean?
So the peak is when you give, like if you were to draw it on a graph, within an hour, it's gonna be at its highest, its strongest,
Right.
right? It's gonna go up and be attacking sugar at its max effect, and then it's gonna drop down and go away out of the body. So if you were to draw it on a graph, you'll be able to see a peak. But for patients, to me, the peak is when they're likely to start having symptoms of low blood sugar, right? If their dose is too high. So peak can be important for clinicians as well as patients. So I want you guys to think of both.
So you're looking at peak in the sense of when can this person potentially experience hypoglycemia?
Correct.
Or long and ultra lasting because it's that extended with those, they never reach that potential.
There is no peak. So if you look at the pharmacokinetics of long acting or ultra long acting, it's flat. That's why it's called your basal insulin or your background insulin. It's gonna be consistent throughout the day. So that's why it's kind of important. So patients try to get slick in clinic and they think that they can sliding scale Levemir, but that's not how Levemir works. You give it, it does, and so that's, I think, and making sure that patients kind of understand how long their insulin acts helps them be more consistent with it. And they're less likely to self-adjust their insulin, which they commonly do in practice. But please marinate on this slide, make your flashcards. So insulin is broken up into basal, right, which is our background insulin, and that's degludec, glargine, degludec, and NPH. And they mostly focus on fasting glucose levels. So if your patient's waking up, their fasting sugars are above target, then you might know they might need a change in their basal insulin dose. And this makes up about 50% of the daily insulin requirements. We're not gonna cover dosing, I believe my colleague is covering it, but the better you understand the products, the easier learning dosing will be. And our bolus insulin, that's also called like our mealtime insulin, and that includes regular, aspart, glucine, lispro, and inhaled insulin, which we'll cover. And these focus on mealtime sugars, and we talked about the peak that they have. And this makes up about 10 to 20% of the daily insulin requirements at each time. Alright, so administration time is really important. This is good for patients to know. They have to give insulin at the right times in order for it to be most effective. So if they're on a rapid acting insulin like Novolog or Humalog, they would give it to themselves 5 to 10 minutes before a meal. If they're on a short acting insulin preparation, so that would be like Novolin R or Humulin R, then they would do that 30 minutes before a meal. If they're giving themselves NPH, that's also 30 minutes before a meal. And you can mix NPH with other faster acting insulins. And we'll discuss that as well. If they're giving themselves Levemir or Lantus or Tujeo, then they should just be consistent and do it at the same time each day. Doesn't matter morning or night as long as they're consistent. And if they're giving themselves a mixed preparation, like our 70-30 or 50-50, then they give it before morning and evening meals. So this is something we're going to practice as a group, is how to convert insulins. There might be cases in clinical practice where your patient's having hypoglycemia, and you might need to change them to another insulin product. Or because of their insurance change, they may not cover Novolog, they cover Humalog, you might have to switch it out. So I have this chart here to teach you guys how to convert the insulins. You can convert, example, Novolog to Humalog, or you can do Novolog to Novolin R, or you can do premix to premix if you need to. And I have the conversions. Most of them are unit per unit. So if they're on 10 units of Novolog, they'll be on 10 units of Humalog. And we'll practice this as a group. And I encourage you to practice this when preparing for the exam. So sometimes there's a little math required. If you start going from NPH to other long-acting insulins, most of the time it's converted unit per unit. But for example, if you're going from NPH to Lantus, and the patient's giving themselves NPH twice a day, you have to take that daily dose, reduce it by 20%, and that'll be your new Lantus dose once daily. So there are some caveats to switching insulins, especially when going from NPH to Lantus.
I'm sorry, what's NPH again?
Intermediate insulin, or like Novolin N or Humulin N. So I have those classified for you on the previous slide. Okay. And then if you're going from a long-acting product like Lantus to Jaya, or Lantus to Placebo, which is more ultra-long-acting, there may also be a 20% reduction that's required. So it's not too bad, just meditate on it. Most of the time it's 1-to-1, and there might be some times where you might have to reduce the total number of units by 20% to make sure the patient doesn't have hypoglycemia. All right, so for my chart people, I found this and it's published by Diabetes Education Services. This company helps people prepare to become certified diabetes experts. So it has all of the insulins listed for you. It even tells you when they expire, at room temperature, how many pens come in a box, and how many units can you dial up. So that's an important concept to know. So for example, this is a flex pen, so this would be Novolog. And according to this chart, it can only dial up to 60 units. And that is true. It can only dial up to 60. So I think it's pretty cool to have this. So like when you go on your rotations, you're working with your patients, especially for advanced care settings, it helps you be more familiar with your insulin products so you can better counsel your patients. They even tell you on this chart which ones are available without a prescription, how they come. So some come in vial, pens. Pump there is means you can put it in an insulin pump. So some insulins are compatible with pumps. And cartridges as well. Some pumps require cartridge placement, so it lets you know which ones are compatible with diabetes technology. So take time to review those. Same thing, page 2 is the long-acting insulins. They also give you information on the concentrated insulins and the mixtures. And I sent this to Dr. Davis, hopefully he uploaded it for you guys.
Yeah.
So
And
I love this cheat sheet.
the ones that don't need a prescription, those are all vials, they're not any pens.
Usually, yes. Yes. Alright. So I kind of touched on insulin concentration a little bit. But we talked about the 200, 300, and 500. So basically, sometimes patients start getting insulin resistant and their bodies need a lot more consistent. I'm sorry.
Sorry to interrupt. I know like in some previous lectures are also telling us that some insulin is available over the counter at
Yes.
Walmart.
Yes.
It's pretty cheap, but how do patients like actually go about getting insulin over the counter? Like, do you just walk up and say, I have diabetes, I need insulin?
No one's ever heard. Yes, you can tell them they can request their Healing arm, yes, and they're about maybe $25 at Walmart.
And so like, with that, how does like Walmart control who gets it? Because like, say like my dad needs insulin and he already really got some, I can go the next day and say, hey, I need over-the-counter insulin. And like, I could tell another one of my family members to go get it also. So like, how do they regulate it?
It's not, you scan it like an OTC product. When I worked at CVS, like when I used to work at CVS, you would go to the fridge and you could scan it and it actually bring up on the label and be marked as an OTC item. And then it would be part of our delivery and we replace it as we need it. But there's no regulations on the amount of insulin that you can purchase. So insulin concentration, some patients start needing a lot of insulin volume, a lot of units. So they make these more concentrated insulins to where the patient can get a larger dose, but in a small amount of volume. Trying to put 100 units of anything and inject that is not comfortable, it doesn't feel good. So you might be able to convert a patient to a more concentrated insulin to where they don't have to put as much volume in their body and help them be more adherent. So I just wanted to kind of explain that and the purpose of the more concentrated insulins and why they're available. All right, and then again, the guidelines list the AWP for a lot of these insulin products, and Walmart's probably the most cost effective for some of them. And I believe they have these denoted too on which ones can be purchased without a prescription. So let's do some knowledge check as a group, and feel free to use the cheat sheet. Okay. So can I get a reader?
What is the alternate name for Apidra?
Any takers? What is the alternate name for a heater? Anyone? So do your best to use the few questions from Rain. What's the onset of action for regular insulin?
I think
Here,
C.
So for the essence of time, it's just, yeah,
Oh.
the essence of time is 30 to 60. Alright?
Oh.
Pure Boss, intermediate acting insulin preparation should be administered 30 minutes before a meal. So that's not on cheat sheet, that's something we talked about on one of our starred slides. Yeah, that is true. So an example of our intermediate acting insulin would be like our MPH, okay? How long does insulin degludec last at room temperature? That would be 128. Not degludec. Yeah, 56.
Okay, John.
Okay, 56. A lot of insulins do expire after 28 days. Some are 42. U500 is 40, depending on if you're giving the bottle or pen. So as you can see, there's different situations, but it's good to try to memorize as best you can. You can maybe guess 28 might stay 5, because a lot of them are 28. Alright, which of the following are available brand names for insulin Pro? And there's more than one answer. Yeah, Humalog, okay. Adderall,
Trujeo.
So B.
No.
Yeah, so Trujeo is our concentrated glargine.
Okay.
So the others are available trade names for Lispro. Alright, so on the test you might have.
Oh, right.
Answer. Okay.
Select all that.
Alright.
No, she was a lot, man.
Wait, I am. I'm not saying with you guys. Which of the following insulins decrease postprandial glucoses? Mealtime sugars. So I'm hearing some. So the Aspart and regular. Right, I had a slide dedicated to that. So glargine and Dedmir are long acting, and the other two options are bolus insulin. Alright, what are the components of Humalog mix 50/50? So it's lispro-protamine and lispro. So when you're reviewing, go back and make sure you know what those other ones are. What are the trade names for those other items? Okay? True or false, Novolin 7030 is available to purchase without a prescription.
False.
Use your cheat sheet.
That's true.
Yeah, it's true.
What?
That's the question I was asking.
Yeah, 'cause
I blocked that in my brain.
I thought Alexa was talking about regular
No,
insulin.
she said.
Yeah, that's-
Some of them are. There's more than one that's available without a prescription, so I need to.
I thought it was just
I thought it was just regular.
Regular, no.
Yeah.
Look on your cheat sheet, there's multiple ones.
Oh.
There's available without a prescription. Alright, so, landmark trials, we'll do this one quickly. So we have the diabetes control and complications trial. In this trial, they put patients on insulin and realized that if they inject more and we intensify insulin therapy, their outcomes are better. Their A1Cs look better. They're less likely to have complications. So that's why the guidelines recommend starting some patients on a basal insulin and adding mealtime insulin as necessary to help get them to goal, especially when managing type 1 diabetes. So we're gonna switch to patient counseling. We're almost towards the end. So it's important that patients know how to use these products. I'll let you guys read these. Feel free to YouTube. It's a great resource for like my visual learners. When you're not sure about something and you just get tired of reading, just watch YouTube videos. There are great things out there. But basically, what's really important that patients don't do is that if you're using NPH or premixed insulin, they don't swirl it back and forth to mix it up. It's a mixture. It has to be consistent before injecting the medication. And of course, patients like to reuse injection supplies, so we always counsel them to get a fresh syringe each time. Mixing insulins can be confusing, but it can help patients reduce injections. Some insulins are compatible together. You can mix regular insulin with NPH, for example, in the same syringe. You can draw up the regular insulin first and draw up the NPH second, and the patient can inject them. 30 minutes before a meal. And YouTube it, because we don't have time to cover it today, but just know that some insulins can be mixed. They have a great resource for when you go into your rotation site. It's called Global RPH. And you can literally type in the insulin. It's like the insulin, it'll tell you it can be mixed with other insulins. So if your preceptor asks you that, or if your nurse asks you that on the floor, it's easy to look at. And if it is compatible, Global RPH will tell you how to mix it the proper order. A lot of times pharmacists don't mix it. It's something that nurses do, but it's just good that we know which ones are compatible. And if you don't know, you know where to look it up. So our insulin pens, we kind of looked at these, right? Pens are so simple, and it's a lot easier to use, especially if your patients have dexterity problems, if they've had a stroke, or if they have really bad neuropathy and they can't draw up a syringe, then a pen is easy. Even people who have vision problems can use a pen. You can actually count your clicks. So even if you can't see, you can count your clicks and know how much insulin you're giving yourself. So pens turn by 1 unit. So if you can't see, you can count however many units you need to inject. So there's no excuse not to use your insulin pen. All right. And I always tell my patients to make sure that, remember, if it's NPH or a mixed insulin, they still swirl it back and forth to make sure it's mixed. And you can actually check out your insulin and make sure it's clear, make sure there's no salt. It doesn't look brown or discolored. You're not keeping it somewhere hot or freezing it. And insulin pens require priming. Do you guys know what priming is? What that means?
Let a little bit come out.
Yeah, it's about 2 units. So they would put on the pin needle, take off the cap, turn it to 2. If they see liquid come out at the top, it's ready to go. If not, repeat the process a second time. And if it doesn't work the second time, then the pin might be defective, it might need to be replaced. But they prime a pin the first time they use it. Once they're using the pin, they don't have to go back and prime it, they're wasting insulin. It's just the very first time they take it out of the fridge and you're ready to put it in their body. So delivering an injection site, I have some crazy stories about injection sites. So insulin can be administered in the abdomen, the thigh, the buttocks, or the arm. I've had patients do crazy things. I had a patient who was injecting in breast tissue. She was like, it doesn't hurt. She was controlled. That was the crazy part. Her A1C was controlled, but I asked her to move it because that's not a steady site for insulin absorption, right? So of course, the tummy is better. Yes.
Oh, no, go ahead.
Okay. So of course, the tummy is better. It's a good place to inject because you have some subcutaneous fat there. I like the back of the arms. So sometimes patients inject here, they get bruising, they get hard spots in their skin, especially if they've injected for a very long time. So we start talking about using other injection sites. So in order to get the arm, I tell patients to put their arm on the back of the chair and then use this part. And it's very simple, you can see it to inject your insulin in the arm. If you trust somebody, they can help you put it in the butt, especially maybe if you're doing it once a day, or if you have a caretaker, right? And then the thighs can work if you don't have super muscular legs. So you can use any area of fat along the side of the thigh. Question?
The mixtures, the second number, that's the regular insulin?
That's the short acting. So the beginning number is always the longer acting number. There you go, long and short. All right, so when we tell patients to rotate sites, I've had patients literally inject and turn the needle. That's in the know. So you have to be very specific about what you need. You have to demonstrate it. You have to show them because they'll go home and do some crazy things. So that's a little bit of caveat about injecting. So always tell patients to use new pin needle, new syringe. Don't share supplies. You can get infections that way. Diabetics are prone to skin infections. So don't share supplies. A lot of people like to do that, especially with family. Don't use anything. I don't like patients to inject something that's straight out of the fridge and that's cold. It doesn't feel good. Usually it might burn or sting. So I have them wait and let it get to room temperature, and that's even with our GLP-1 products. Prime the insulin pens before use, and also know your insulin expiration dates. So for example, patients are non-adherent, they open up a bottle of insulin, they opened that bottle of insulin 6 months ago, they go back and inject old insulin, like that expired 28 days after you opened it. It's no good. So they're injecting insulin that's not potent, their sugars are still high. I'm using my insulin, I don't know why my sugars are still say something expired. So that's a very easy counting point. I tell my patients, when they open up their box, there's a date, there's a place for you on your date for when you open up your insulin. So they can start being accountable of, how long their supply will last. So U500, that's our most concentrated insulin. It's 5 times more concentrated than our U100 products. You consider this in clinical practice in patients who have insulin resistance or their total daily dose is more than 200 units per day. And it can be dosed 2, 3, or 4 times daily before meals. And the storage is different depending on if you use a vial or a pen. So U500, there's a lot of dosing errors that happen with it because it's more concentrated. And U500 itself comes with a green cap, and it must be dispensed with a U500 syringe. And I have an example of one. Please don't go so. So you can see how many units you can draw up of U500. So a U500 syringe goes all the way up to 200 units, and you don't have to put as much volume. You don't have to inject as much. Yes, but green cap, green syringe. So make sure you don't give the patient the wrong syringe because it could lead to a dosing error. Right? Okay, so let's transition quickly to our inhaled insulin. Been a pharmacist for a while. I've never dispensed it, never seen it. It is available. It's inhaled insulin. It's a dry powder. And it comes with little cartridges that the patients would place inside the inhaler. And it's dosed at 4, 8, or 12 unit increment cartridges. And they would inhale the medication before the beginning of each meal. And because it's inhaled, the side effects include cough and throat pain and irritation. And anybody that's living with asthma, COPD, or chronic lung disease, or if they recently stopped smoking, we would not recommend this product to patients. So this could be an alternative for patients who aren't willing to inject, but they still need a rapid-acting insulin.
Would this be a good choice for kids or children?
You know, I don't know if it's FDA approved in children. I think that's a great question. That's a great question. I would have to know that. Never used it. There is a conversion chart from the manufacturer of how to convert between mealtime insulin, like if you're taking them off of injection and then putting them on the inhaled insulin. You don't have to know it, just know that it exists. Okay. And then, depending on how much the patient is inhaling, they have different combo packs that you can, the provider can write for and that you can order. And this was a chart that was made by the manufacturer that I thought was helpful in the event that you ever came across this product in clinical practice. So lastly, for our special drug formulations, we have the combination of insulin with the GLP-1 receptor agonist. Our first one is Zoltify, and it has Degludec mixed with liraglutide. And it's good to note that when you turn the dial of the Zoltify, you're dosing the amount of insulin. So basically, it's pre-mixed. When you go up on one product, you're going up on the other, and it's already preset. The titration schedule is here for you guys, and your starting dose depends on if the patient's ever had insulin or a GLP-1 or not. And again, these must be dispensed with the medication guide. Our other special formulation is the Soliqua pen, which has glargine and lixisenatide together. It's given once daily. Again, when you turn the dial, you're dosing the number of units of insulin, and it's fixed dosing. But that is a good option. So if you have a patient that's on these two products separately, they're tired of injecting but they're stable, you can convert them to this one product and they only have to do 1 injection per day. So that's a person that you might want to use this for. Alright, so remember, patients that are injecting, they're going to need a glucometer, test strips, lancets. They might need pen needles, syringes, and they might be eligible for diabetes technology. Diabetes technology includes like your CGM devices and your insulin pumps. So you might see some of these things for patients that are using injectable therapies. So I bought some syringes for us to take a look at. Right here. And as a student, I remember being confused with syringes when patients would come and ask for it at the counter. I was like, what do you want? Long, short, what? So they come in different sizes depending on how much insulin the patient is using. So for example, a U100 syringe goes up to 100 units and it counts by tubes, which is good to know. This is what your patient needs. So don't tell them to inject 13 units. They might be confused. diabetes, they may not be able to find 13. Because I have patients with low health literacy. They can find 12, they can find 14, but some people don't think that way. So being able to kind of see what the patient sees, I think is helpful. And then your half cc syringe goes up to 50 units, right? And this goes by ones. So if they're doing 7 units, for example, they can find 7 in the plunger, which makes it easier for patients. And then lastly, you have your 3/10 cc, which goes up to 30 units, and it goes by ones. Let's look at that. And you see orange cap, right? So this goes with our U100. And the green cap, the green syringe goes with our U500. All right, and then lastly, the needles. The guidelines actually recommend patients who are using pin needles for diabetes management on their pens to use the 4 millimeters in length. Not too long, not too short, just right. And usually they're prescribed anywhere between like 30 and 33 gauge. So you'll see different gauge lengths, different needle sizes, but the length is important. The guidelines recommend 4 millimeters in length. Medication safety. So insulin is a high alert medicine. There's a lot of medication errors. Here, I don't know if this is 60 regular insulin now, 6 units of regular insulin now. So if you ever see an order, it's no longer appropriate to just put the provider has to spell out units because there's a lot of dosing errors with insulin, which can be dangerous to the patient. And as we noticed, the names are very similar. So you might have people mixing up Novolog and Novolin or Humalog and Humulin. So it's important as pharmacists that we're able to help providers keep this straight to minimize dosing errors. All right, so our last batch of knowledge checks. Anybody remember the components of Zoltafy? So there's more than one answer.
C is there. And
Okay, that's right. So
oh,
A
A
and
and
B
B.
is Zoltafy, and the other two options are the components of Soliquin.
Oh, that's Siliqua.
All right, true or false? 8 regular cartridges are available in 4, 8, and 16 units. False. Yeah, so it's 4, 8, and 12. Okay. How often can U500 insulin be dosed per day? We're gonna select all that apply. So it'd be 2, 3, and 4 times daily. So a little caveat about E500. So this is our most potent insulin. We give this to patients that are injecting large volumes. Once you're converted to U500, you will not be on any other insulin product. So if you give somebody U500, this is the most potent concentrated insulin. They won't need a Lantus. They won't need a Levemir. U500 is going to do its job. And they're going to be on it a minimum of 2 times a day and up to 4 times a day. Most of the time in clinical practice, you see it administered breakfast, lunch, and dinner, just 3 times a day. But there might be some patients who are on it 2 times a day or up to 4 times per day. All right, so we're at the end. I want to do some cases together, and I will need 3 volunteers. Any takers?
Tariq?
To come up here.
Oh.
We're gonna answer questions, and your class will help you. I appreciate volunteers and participation.
We don't gotta read, I know.
No, come up.
We don't gotta read.
All right. And I need a second and a third. You don't have to come up right now, but we have 3 cases. Because I need a second and third volunteer. All right. So go ahead and read the
In middle school, y'all don't laugh at me, man. JD can't read. Case 1. LT is a 44-year-old female who reports to the clinic for diabetes management with the clinical pharmacist. She states that she was recently discharged from the emergency department with uncontrolled hyperglycemia. The ED provided her with a 30-day supply of Adderall, Adderall, and 8 units 3 times a day before meals, and Novolin and Relial 20 units twice a day. You decide to convert LT to the available formulary units, which is the Novolog pen and Atlantis pen, what is LT's new insulin regimen?
So basically, this case, we're going to convert insulins, right? So let's say patient went to Memorial Hermann, and Memorial Hermann gave her this. But she's coming back to see me at Harris Health System, and this is what the Gold Card covers. This is what our formulary covers. I gotta give her what's on the formulary. So how do we convert her? What's her new insulin dose? So we're gonna use our tables with our unit conversion. So how I would first approach this case is I would look at Admelog and figure out what type of insulin is that. It's rapid, okay. So we're gonna convert her to Novolog. What is that? So the conversion for rapid to rapid is what? Okay, so her new dose of Novolog would be the same. All right.
Okay.
So see, it's not that bad. All right. So the second part of her insulin regimen is the Novolin N. So you know when you see Novolin N, you might have to do a little math, right? So Novolin N is our what? NPH. Okay. And we're converting her to Lantus, which is classified as what? Long acting. So what did the conversion recommend when going from NPH to Glargine? Especially if your NPH is twice a day.
To longer?
Yeah, we're gonna take NPH to the Lantus or Glargine.
It says,
Correct. Yes. So what do you do when it's twice a day? How much do you reduce by?
20%.
So what's 20% of 40?
I got you, Brittany.
We're listening.
Come on, future.
8.
Thank you. So her new Lantus regimen would be 32 units daily. So it's not that bad when you think about it. Okay.
Ooh, I wish we could write that down.
So I got this. So the rationale is first to go from rapid acting to rapid acting, which we talked about.
Mm-hmm.
So 8 units of Admelog is the same as 8 units of Novolog.
Okay.
All right. So when you're going from NPH to long acting, you take the total daily dose of the NPH and you reduce it by 20%.
Okay.
So now her new regimen is Novolog 8 units 3 times a day before meals and Lantus 32 units daily. Okay, stay with me, friend. We have a part B. Go ahead.
Never my name, okay? Change your function number.
Mr. Fargo.
Yes, ma'am. Case 1B. The clinical pharmacist has determined LT's new insulin regimen. How long does the Lantus pen and Novolog pen last at room temperature once opened? First question.
All right. So we're gonna use our cheat sheet
28 days.
for both.
One was 56, one was 28.
No, only for
42 for something.
Okay, y'all.
Hold on.
All right, let's start with Lantus. What does the cheat sheet say for Lantus pen?
Lantus is 28 days.
Okay. What does the cheat sheet say for Novolog pen?
No.
It's 28 days.
28 days. Okay.
Ah.
I want you to be sure. Don't be throwing out 28 because you think it's right. I want
Now
you
this
to be
is
sure.
Resto was 56 and there's a couple other sides go
Yeah.
28 more more.
Yeah, I mean, I want you to be sure because if you tell a patient, I want you to guess, and you got them throwing away insulin, right? Okay.
Alright, second question. What is the maximum amount of units that can be delivered in one Lantus pen and both Novolog pen?
So when you open up a Lantus pen, and I have one here, what's the max that you can dial Lantus to? And you can use your cheat sheet.
What slide is there on
It was on our cheat sheet from the diabetes services.
I know Novolog is 60. I'm trying
Yes,
to find
Novolog is 60. So how much can you dial it?
80 units.
80.
What side is that?
It's on that chart it's in the slides, but it's also a separate document.
So Lantus is good at 28 days at room temperature once you open up the vial, the bottle, the pen, excuse me. And you can dial it up to a max of 80. And no blog saying it's good for 28 days with a max of 60. So now you guys kind of think of, this is how I'm going to have you guys apply what you learned in a case.
Okay,
All right, thank you, Mr. Vaughn.
I see it.
All right, can you go back? Can you go back? Oh, sure, I'm sorry.
So, okay.
Thank you. All right, and can I get a second volunteer for case 2? Somebody, anybody, for case 2.
AJ is a 50-year-old.
Yeah, about to say,
Come on.
It's fine.
Don't be shy.
AJ is a 50-year-old female who reports to the clinic for diabetes management with the clinical pharmacist. She is living with type 2 diabetes and currently using basal insulin therapy and metformin to control her glucoses. She expresses interest in a drug that would aid in her weight loss efforts in addition to lifestyle modifications. Which of the following medication best fits this description? Dun, 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 dun. Victoza, let's see what we have.
Is that your body on too?
I don't know.
Going once? Okay, here we go, Victoza.
Wait, come back, we got more. We got more. Okay, so yeah, Victoza is the option. So what I've listed of the injectable products, the other 3 were insulins, and insulins are associated with weight gain. So the most appropriate option would be Victoza. All right, so part 2.
The clinical pharmacist decides to start AJ on Victoza for glucose management. What are the pertinent counseling points for Victoza?
So basically, I have a Victoza pen somewhere. So how would you tell AJ how to use Victoza?
Class.
No, come on, they can help you out.
Okay, so we would encourage our patients to increase fluids and drink sugar-free drinks, carbonated beverages to reduce GI upset, and develop a meal plan that includes smaller and more frequent low-fat meals.
But yeah, how I use it, where I put it.
Oh,
How I store
okay.
it. How long is it good for?
Oh,
Right, so remember, Victoza has the 3 doses on the pen, and they start at 0.6 milligrams.
oh, the 1.2, the 1.8.
Correct.
Yeah, okay.
Alright, so you have to tell the patient like, hey, you're gonna start this medicine, we're gonna start you low for your body to get used to the medicine. And you'll do 0.6 milligrams daily for the first 7 days. You won't see a change in your sugars, but when you go up to 1.2 milligrams, you'll notice that your sugars will start to change. Because you're using this product, I want you to check your fasting sugars and your sugars 2 hours after your largest meal of the day. So some of the side effects, can you all remember the side effects of Victoza?
Nausea, vomiting, cramps, stomach cramps.
Correct. They may not feel good. If they eat greasy, fatty foods, they may not feel good, right? So we're gonna make sure to also tell the patient to prime the Victoza pen. They're gonna store it in the fridge until they're ready to use it. And once they start using the pen, it's good for 28 days, right? So also let's talk to the patient about side effects. We talked about that, but what are the benefits? So I like to tell patients, I like Victoza. You might notice some weight loss. Like patients in clinic, they only lose about, I would say about 10, 12 pounds with Victoza, which can be substantial for patients. It helps protect your heart. It doesn't damage your kidneys, which is, the more they know about the medicine, the more likely they are to use it. Okay, and then they'll have to use pen needles with this product. They'll have to screw it on to the pen, okay? So that's how I want you guys thinking. Oh, there was more, but I'll help you out. So the clinical pharmacist decides to start the patient on Victoza. When should AJ return to clinic for follow-up, and what should be monitored? I noticed that when patients come, when students come to site, they don't really know how to do a plan or when to tell the patient to come back. So what would you recommend for a patient that you gave an injection to? When do you think they should come back to see you? Yeah, so in about 4 weeks, I agree. So they can come back in 4 weeks. You can maybe ask them how they're doing with their injection. Are they having problems, any burning, itching, bruising? Make sure that they went up on their dose. We don't still want them on 0.6 4 weeks later, right? And we want to make sure that if they've had that nausea, vomiting, we can tell them how to, remind them how to mitigate those side effects. and we want them checking their sugars, and we'll monitor their home glucoses and their A1C and renal function. All right, one last volunteer. Anybody? Donation. Thank you, Mr. Rondon. Our last two.
It just flow.
Okay, CC, the 28-year-old male who was the first in the clinical pharmacist for diabetes management. CC is living with type 1 diabetes and currently has an A1C above goal at 11%. CC's current insulin regimen includes Humalog Quick Pen, 80 units 3 times a day before meals, and Leathermere Flex Touch Pen, 100 units twice a day. During the visit, CC admits to non-adherence due to injection burden. What changes could you make for CC to improve glucose control and reduce the injection burden?
So we're gonna pull out our cheat sheet, right? Do you have any ideas? What do y'all see here? I see somebody who uses a lot of insulin.
Maybe we should find a combo drug so they
just
don't
put
have
them on
to.
the 500 one dose pen.
Okay, well, not one dose, but that's an option. We can only use 500, but let's look at our cheat sheet, let's dissect something.
Okay.
So they're on Humalog pen. How many units can we turn up to in Humalog pen? 60. But the patient is on 80, right? So how many units can we dial up with the Leathermere pen?
80.
And the patient's prescribed 100. So if they go to their doctors don't know this. They just say, go up on your insulin, go up on your insulin. And the patient's at home like, I can't. My pen only goes up to 60 or my pen only goes up to 80. So what could be happening is the patient, if they're doing it right, they have to poke themselves at least 10 times, which is a lot, which is probably why he's not here. Or the other option is that the patient could just dial up to 60 and stop, and dial up to 80 and stop, and their body's not getting enough insulin. So those are things to think about, right? So the simplest idea would be to just take them off the pen and take them off the pen and go vial. So I showed you a U100 syringe where you can pull up to 100 units. Right? So you don't have to poke all that. So that's simple, that's an easy fix. Take them off the pen, put them on the vial. That could be spare non-adherence. Okay? So I want you guys to figure out how to think, how to solve problems for your patients.
So instead of changing the drug, just change the tool.
Yeah, you could change the dosage form, okay? And then we could do like what Mr. Fonda mentioned, convert them to 500. So if you calculate CC's prescribed insulin dose per day, he's on about 440 units per day. All right? So for the rule of thumb, if the patient's taking 300 units or more daily, you can give U500 3 times a day. And they recommend a breakdown of 40% of your dose, total daily dose with breakfast, and 30% of the total daily dose with lunch and dinner. So if you were to do the math, we have a new U500 regimen for CC, and now he's down to 3 injections per day. Maybe the sugars will be better controlled.
So why is that option 2 when the issue is like injection? Because if you change the formulation, you don't change the amount of injections, but here you do.
Yes, so basically, he could be doing up to 10, right? By switching him to the vial, we go down to 5.
Right. Yeah, I was saying, because I feel like this one you get less injections as well as the accurate amount of insulin that he needs by having it.
So this case is to show that diabetes management is an art, and you have to look at patient's preference. CC might say, I like what I'm taking, I don't want to change, right? I don't want to go to U500, this is new, I've never had that. I'd rather stick with what I know and just go to the vial. So we have to go back to those patient preferences, but that's a good point, that's a good question. But I just wanted to show that with this one case, you have options, and this is just option 2. There's a third option, but.
So pretty much always have more than one option because your patient preference is always affected.
Correct. So when you get to your after your patients and you start working of your patients, I always have my students create multiple parts of the plan. So you might have option 1, but the patient shoots that down because they don't want to inject. So what would be option 2? What would be option 3? Right? So that's why it's important as pharmacists, especially with diabetes management, we know all the tools that we have and what the patient is eligible for, and we discuss these options with the patient, and let them pick which one they would rather adhere to. But as we can see, B500 he's eligible for because of the high amount of insulin, and you can say, hey, CC, you only gotta do 3 injections per day, let's try it, at any point, okay? And the last one was kind of complicated, so we'll just put together. You can switch the patient to a concentrated insulin, like the 2JO or the Tresiba, and still keep them on a pen. And I believe in this case, he was on Humalog, right?
Mm-hmm.
And Humalog only goes up to 60. But if you use your cheat sheet, there's a form of Lispro that dials up to 80. So you could just switch them 1-to-1 to Analog, okay? So just to give you examples of how to know your products and what they draw up to and what the options are. And then here I have the conversion of how to go from Levemir twice daily to an ultra long acting product. So remember, we got to do that 20% reduction, which is how we come up with the new insulin regimen of 160 units per day. And if you look at the Tresiba and the 2JO, they're both, the pens can both dial up to 160. Okay? So there's no right or wrong answer. This would be what the patient is willing to do. I just want to give you guys a case of how to apply your cheat sheets, how to apply what we've learned, and why it's important to understand our injected products. Okay? So the last thing for me, my expectation is that you know your brands, your generics, and dosings, especially for your GLP-1s, right? And for your Stimulin, their amylin and watermelon, so know your dosing for that product. Be familiar with the A1C lowering potential, be able to recall those clinical pearls that we talked about, be able to classify and compare your insulins, know which one's rapid, which one's intermediate, and then know how to convert between your insulin products, like we practice, okay? And then make sure that you know how to recall counseling points for how to use the pen and mixed insulins, all right? I appreciate your attention. I hope it's helpful. I'm open to any feedback on how I can make this a little bit better. I try to make it interactive as possible, but I'm open to any feedback. I know it's difficult, it's a difficult topic, but patience needed. Any questions? And I have something for my volunteers.
Hopefully it doesn't have sugar in it.
Probably Girl Scout.
Well, I'm telling you, I have to invite her back.
What is it? That's sweet.
You really go out here.